Good afternoon, everybody. I would like to welcome you to the April meeting of our System of Care Expansion Leadership Learning Community. As you know, the topic of this month's session is preparing to develop a financing plan. Before we get started, I'd like to just reiterate what the learning community is about. The System of Care Expansion Leadership Learning Community is a monthly community designed to support system of care leaders, and that could be principal investigators, project directors, leaders in various contact areas, and others that you might identify. And we also include leaders in non-grantee states and communities that may find the topic area and the discussions useful to their work. We try to address topic areas that are of importance to you, and we welcome your suggestions as to topics that we might address in the future that will help you to meet the requirements of your grants and also to do your jobs as leaders in expanding the system of care approach. Before we get started, I'd just like to mention our plans for next month. Since there'll be a meeting in late May, we won't be having a learning community call. But we've gotten a number of questions from some of you about match and primarily what's allowable and what's not. And we did have a learning community session on that topic last year. So in May, we're going to send you the tape of that webinar, as well as the PowerPoint slides and the resource materials that we provided to last year's participants. And hopefully that will be helpful to you. And if you have specific questions, we may be able to help you, or we'll refer you to grants management or your GPO for specific questions related to your own grant. We will resume in June, and we're working on a topic for June, but again, are always open to suggestions you might have because we want to make this as responsive to your needs as possible. I know you've already heard this, but we'd like to invite you to put your comments and questions in the chat box throughout the webinar. We'll do our best to respond, but it's really a good way to get some dialogue and interaction going during the session, so please take advantage of that opportunity. For this particular meeting, our objectives are to focus on preparing to develop a financing plan, what should be included, what you should consider for strategic financing for expanding and sustaining the system of care approach. And I'm going to start off with talking a little bit about the financing plan for system of care expansion that's required in the expansion grants, some of the parameters for that, and some of the things that you might think about as you get ready to prepare your financing plan. First of all, the grant FOA requires that you develop a sustainable financing plan for system of care infrastructure and also for services, and your plan is supposed to link with other child-serving systems and with mainstream financing sources like Medicaid and mental health and substance use block grants. And your plan is required to be completed by the end of year 2. And implementation must begin no later than the beginning of year 3. The guidance in the FOA also talks about utilizing third-party and other revenues for services to the extent possible, and to use grant funds only for services that aren't covered by mainstream funding sources like Medicaid and private insurance, or for services that aren't covered sufficiently, or maybe for children who are uninsured. So grant funds are not expected to cover all of the services that you'll be providing. You should be looking to other sources for sustainable financing for those services. The FOA also mentions that you should link with innovative financing like managed care or Medicaid redesign, the community behavioral health clinics that are now beginning in several demonstration states, and also looking at the joint bulletin that was released in 2013, I believe, by SAMHSA and the Centers for Medicaid Services that talked about the kinds of home and community-based services that could be covered under Medicaid and the authorities in Medicaid that you could use to cover them. So all of those are in the FOA as areas that you should consider when you're developing your plan. There are no guidelines for the plan, so that you have a great deal of flexibility to create it, a plan that's tailored to your own approach and your own goals. And also there's no specific format that's required, so there's also a lot of leeway in creating a format that works for your particular context. I think it's important for you to recognize that the plans are not developed in a vacuum. They have to be developed in the context, first of all, of a rapidly changing environment. And you know that at the moment we are in an environment where financing opportunities and structures are changing very rapidly. They may present opportunities for new partnerships, new financing strategies, and also rethinking some of the financing strategies that we've been using for financing system of care services and supports previously. I encourage you to look at this as a dynamic plan that you'll review at regular intervals based on your progress, based on changes in the environment, based on opportunities that come along, and that you incorporate and leverage those opportunities and also customize your plan and revise your plan based on the kinds of challenges and changes you may be dealing with as we move along. There are potential opportunities in the environment that you might want to look at. Braiding fundings, using Medicaid to increase coverage of home and community-based services, shifting funds from inpatient to home and community-based services, and I mentioned the joint bulletin from SAMHSA and CMS that lists, again, a number of home and community-based services that you might want to look at, various waivers, state plan amendments, and to leverage opportunities to finance these services through new structures like health homes and through other kinds of structures and opportunities. For example, money follows the person and various kinds of state plan amendments and Medicaid expansion. Many states have taken advantage of those opportunities already, and if you have not, these are areas that you should consider as opportunities for financing the services and supports that you'll be providing within the system of care framework. Also, block grants, which are used, both substance abuse and mental health block grants have been used extensively to fill gaps in services that aren't covered by Medicaid or by other sources. And there are financing opportunities, as you know, in partner child serving systems, whether it's child welfare, education, juvenile justice, early childhood, and all of those are opportunities that you could leverage to provide sustainable financing over the long term for the services and supports, the home and community-based services and supports that you'll be putting into place through your system of care initiative. One of the things that I think is important to recognize is that the system of care expansion grants are not intended to fund all of your services and supports. We like to think about it as venture capital, that it can be used to provide a foundation for future financing. It's short-term funding to use for startup costs, for building capacity, for putting services into place. Also can be used for demonstrating new financing strategies and how they can be leveraged. And for negotiating cross-system investments, for example, by demonstrating good outcomes to partner child welfare, juvenile justice, and other systems to demonstrate positive outcomes and return on investment from the system of care approach, and working with them to invest their dollars in systems of care, and modifying what existing financing streams will pay for example, what is covered under Medicaid and under some of these other funding sources that might be available to you. So securing commitments to redirect funds to more cost-effective services, providing data, as I mentioned, on return on investment, but thinking of your system of care funds as venture capital, as money that you can use to get things going. These grants, of course, only last for 4 years, and the idea during this period of time is for you to create financing strategies and mechanisms so that you can sustain the services and supports that you put into place over the long term. Another point that I think is important for you to recognize is that a financing plan can't be created in a vacuum, that it has to be an integral component of what your expansion plan is and the objectives that you lay out in your expansion plan. So that when you're looking at creating your plan, it should clarify what you need to achieve your specific objectives and review the funding that's available to achieve those. And then look at what are the possible financing strategies that you can use to achieve your goals and to establish financing priorities. What are you going to work on based on the priorities of your expansion efforts and what you have in the plans that you've created to implement and expand and sustain systems of care. And then, of course, the plans need to identify action steps that you'll take to obtain financing from the sources that you identify and responsibilities and timelines. But the important message here is that the plan needs to be, the financing plan needs to be an integral component of your overall plan and linked to the objectives that you want to achieve. What are the steps that you might use in creating a financing plan? We tried to outline those for you, and there is, by the way, a sheet that presents some guidance in creating a financing plan. These are some of the things that are included, and we will make sure that you have access to that. But the steps that we've identified are, one, organizing an appropriate work group to develop the plan. You can use an existing team. Most of you have an expansion team that's already working. You can use that team or work group. You can create a work group and add individuals that have specific expertise in financing and use that work group to create the plan. And you also, again, need to identify as step 2 your expansion objectives. There's a worksheet that you might be able to use if you like to identify your objectives and then to identify and specify the financing that you're going to need to achieve each of those. The third step would be to identify and analyze the financing needed to achieve your objectives, current utilization, current expenditures, what strategic opportunities there are, what are the gaps between what you have and what you need, potential new financing, and Sheila will be going over this in considerable detail during the rest of this webinar. And then another step is to determine how your system of care grant funds will be used to create that kind of plan and to lay the foundation for future funding. The fifth step is to develop the strategies that you're going to use to create or modify or realign funding for system of care expansion. Sheila will talk about this as well, but some of the major strategies are to redeploy resources that you're already spending, refinancing so that you can maximize public funds, braiding, coordinating, integrating funding across agencies, creating new financing mechanisms, and raising revenues. And again, Sheila will go into that in a lot more detail. And then finally, action steps. How are you going to approach this? Who's going to do it? What are your timelines? What are the responsibilities? And what are the intervals for reviewing your financing plan and revising them? As I mentioned, this is a dynamic document and something that you will be using over the course of your grant period, but also something that you'll be using along in the future. The idea here, again, is that you're not creating a financing plan for a grant per se, but you're creating a financing plan for system change. And this is a system change process that shouldn't end when your federal funding ends, but that continues as you reform your children's mental health system and as you determine what are the financing sources that you can use to maintain the home and community-based services. So with that, I'm going to turn this over to Sheila, who will talk about strategic financing considerations and go into a lot more detail on some of the things that I just introduced to you. So Sheila?
Okay, thanks, Beth. Can you hear me okay?
Yes.
Great. So good afternoon, everybody. Sorry to be doing this from the road. We should probably be using some of our money to like fix potholes. But I wanted to talk really about how to approach finance analysis, thinking about dollars. And you really don't start with dollars. You're really trying to, building systems of care has to do with looking across agencies, working across stakeholders to build a common agenda. And the same thing is true about finance. Building collaborative finance agenda across various purchase stakeholders, examples, providers. So Beth, I'm now on the slide that says first question for strategic financing. And that really,
Sheila, this is Beth.
Yes?
Can you talk a little bit louder, please?
Yeah, I can, and I can move the mic closer, too, if that helps.
Much better. Thank you.
Okay. So strategic financing really doesn't begin with the money or the dollars. It begins with stakeholders answering a couple of key questions, which is financing for whom and financing for what? What is it you're trying to achieve, and on behalf of which populations, children, youth, young adults, and or families? And in the next slide, if we look at this as a prevalence and utilization triangle, let's say, which is, many of you are probably familiar with this already. If your population focus were, for example, all children and youth in a state or in a county, 80% of them will not have a need for specialized behavioral health services based on prevalence data, but about 20% of them will. And you may be focusing on all of those children. You may be focusing, on 100%. So you're doing primary behavioral health prevention, for example, universal kinds of prevention activities. Or you may be focusing on a subset of children at the top of the triangle who tend to use a lot of services and are the populations of children and youth that are in residential treatment, like inpatient hospitals or receiving emergency, are often at risk for multiple psychotropic medication use. It's not uncommon to see systems of care begin with that subset of youth because of the opportunities for redirecting the dollars into children at risk. So you begin to experience a return on investment as Beth was talking about. But there are also systems of care that are focusing on all children or on early childhood populations, for example, where you're doing more with different types of systems. And we'll talk about that in a moment. But the next slide are just examples of the various populations that you all and others are focusing on. And being clear about who your population or populations of focus are is really the first step, because everything kind of falls from that. So the next slide on financing for whom, you're not only trying to decide who are we focusing on, but what are the demographics of our populations of focus? Are we covering both rural and urban areas? Are we covering all age ranges, subset of ages? What are the strengths, issues, challenges, needs of our populations of focus? Many of you have those reports, have had them for, you have multiple reports that give you that kind of data and had to do that analysis to apply for grants. But you may be refining that as you're getting building activities. Or you may start out with one population to focus and then move to additional populations. But use your data, because the more you understand about your populations, the better. Medicaid data, for example, can be stratified by aid categories, so foster care, children on supplemental security income, state stability criteria, children who are eligible for Medicaid by income, for income purposes account of population. It can also be stratified by race, ethnicity, by location. That gives you a lot of information about what children are using and who those children are. It can also be stratified by diagnosis, for example, which is terribly reliable, but it does give you a certain picture. Moving to the next, financing for what? So you determine your populations of focus. So the next question is, what do you want to achieve on behalf of your population? And that, of course, is governed by your values. Are you, for example, is a goal to reduce use of restrictive services, so reduce the length of stay in residential psychiatric hospitals? Is it to reduce juvenile justice involvement? Is it to improve access to services? So you really have to be, is it to reduce disparity? It may be a combination of many of those, but being clear about what you want to achieve and kind of within what time frame, what's realistic, is also important to a financing analysis. The next slide, in terms of financing for what, is now that you know your populations of focus and have agreed upon what are the outreach and engagement strategies that you're going to employ? What are the services and support? What's the benefit design, for example, with Medicaid? What are the care coordination approaches that you'll be using? Is there a common practice approach? So, for example, if are you doing intensive care coordination with wraparound, which is specific fidelity-based care coordination approach? Are you using particular evidence-based practices? The answers to all of those kinds of questions have dollars attached to them. They have implications for how much you'll be to have available. The next slide on financing for what? You don't want to just list out a whole bunch of services and supports that you'd like to see in place, but you also want to describe how you'd like them organized in order to ensure access, to ensure children get the right services in the right amount at the right time, and that they don't stay in services for too long, but that they get what they need. And so what's the system design? And often I'll get calls from states or counties and they'll say, help us figure out how to finance, this. What can we do? And my question is, well, what is the this? What is it that you're trying to put in place? Are they changes within the larger Medicaid delivery system? Is it something that you also want to do around child welfare, the child welfare system and how it's organized? Is it the relationship among these systems between mental health and child welfare? And that all has implications for the system design. It's virtually impossible to build a sustainable system of care without impacting the Medicaid, because for most children who are involved in public systems, certain children with specific behavioral health challenges are Medicaid eligible, not all, but most. And Medicaid as an entitlement program is the largest financer of behavioral health for children and for adults as well. And mental health systems, unless they are kind of in charge of the Medicaid match for behavioral health, their dollars tend to be fairly small because they're relying on general revenue from the state and the county and block grant dollars. Block grant dollars, in the grand scheme of things, are pretty small. So you really need to be looking at Medicaid and other big funders of child welfare. The schools also are a major financer of health to children. It's a little bit tougher to get your hands around school financing because there are so many independent school districts. But again, depending upon your population focus, none of those are possible. And then what is the administrative or system infrastructure that's needed? So are changes going to be needed to the management information, to electronic health records, is there training capacity? That's kind of a rhetorical question because system change implies that there's going to be a need for training and capacity building. And how are you financing that? Systems of care call for some type of cross-agency governance body because multiple systems are involved and multiple stakeholders. There's a cost to that kind of a governance body. There's social marketing and communication kinds of infrastructure needed. There's continuous quality infrastructure needed. Not all, but many of those infrastructure pieces exist, but they're not set up necessarily in a way to support what you want. So it's often influencing those that existing infrastructure. And sometimes it's new infrastructure. So, for example, we see a number of states that are developing centers of excellence in partnership also with state universities. Maryland, for example, organization and implementation, and how we obtain that one, that can provide training and capacity building in the types of practice approaches, and in addition, just explaining to people how a reformed system is going to work. Another critical piece of infrastructure is family and youth, our family and youth organizational capacity, because system care are involving and partnering with families and youth as meaningful partners at all levels of the policy level.
Sheila, this is Denise.
Yes?
Your voice is breaking up a little bit more again.
Okay, let me try again.
There we go.
I'll talk right into this. Okay.
Thank you.
So I'm talking about family and youth-run organizational capacity and how family and youth partnership is needed at all levels of the system. And in addition, many systems of care are building capacity for family and youth peer support and system navigators. And that has a cost to it. And that infrastructure, often through family, by infrastructure I mean, for example, family-run organizations or youth-run organizations. That infrastructure is no less important in a system of care than your information technology infrastructure. So how are you going to finance it? And over the long haul. So I remember once working with a local system of care, which stayed with a partner, and every single contract they wrote or grant they went after built into it the family dollars for the family-run organization and the youth organization, no matter what the grant or contract was, because their philosophy and commitment was that we can't do, for example, a clubhouse program with emerging adults or music transition without having a partnership with our youth organization. And we can't do early childhood programs without partnerships with our family organization. So it didn't matter what the contract was. They just wrote it in as a piece of everything, much as they did to support their administrative structure around IT and things like that. Okay, next slide is to get some sense of how much the system of care is going to cost. And, depending upon whether you're piloting something to begin with, or like talking about pilots, phasing something in, let's say, it could be relatively small cost, or it could be a much larger cost because you're actually revamping, the larger system and focusing on a total population of children. The next slide, if you've answered these questions of financing for whom and financing for what, then you're ready to talk about financing in dollars. So if we go to the next slide on who controls dollars for your populations of focus, this is not even a complete list, but it gives you a picture of kind of the major players, which I'm sure you're already familiar with anyhow, because most of you in writing grant applications had to think about who controls dollars for the populations that we think we're going to be focusing on. But doing that scan, once you kind of fine-tune which populations of children, youth, young adults, and families you're focusing on, it is important just to kind of redo that scan. And then the other thing that's important is the next slide that's around major fund types. So there are pros and cons to, not all dollars are the same. And the types of dollars that fit within different agencies fall into one if you can. So you have entitlement dollars, which are mandatory spending for anyone who meets the eligibility criteria. So they're uncapped entitlement dollars. And in our world, the three that are kind of most critical are Medicaid, Title 4E, which is foster care and adoption, and the Individuals with Disabilities Education Act, or IDEA, dollars. Formula grants are the funds that are provided on a non-competitive basis, so you don't have to compete for them like you do discretionary grants. But they go to states from the feds on a formula basis, usually based on population, poverty indicators, things like that. And they may also go from the state to the county, depending upon how you're structured in your state. Or they may just sit at the state level if you're a state-run system. And examples of those are Title 4B, which are child welfare dollars, Title I, which education for the disadvantaged. And there are a number of juvenile justice, Office of Juvenile Justice extensions. Block grants, Beth has already mentioned the mental health and substance prevention and treatment block grant. There are others like the social services block grant, which is also important in our work, a number of others, and they are consolidated grants that were formally separately allocated grant programs. And then there are discretionary grants, which you have to compete for, and the System of Care expansion grants are an example. And then there's state and local general revenue. And that's, revenue that you have in your state and or county that are derived from taxes, from charges, from fees, etc. And if you go to the next slide, there are advantages and drawbacks to each of these. So if you look at formula grant money, let's take 4B, those are flexible dollars and can support things like family preservation. But it's a capped allocation from the federal government to the state or from the state to the county, and it represents a relatively small percentage of available dollars. Uncapped entitlement dollars, contracts like Title III or Medicaid, are large funding sources too, Medicaid, but 4E as well for the child welfare population. But take 4E, it can only be used for room and board costs for eligible children or in out-of-home placement and for certain administrative and training costs, so you can't use it for home and community-based care unless you have a 4E waiver. And so there are constraints around that. Medicaid, also an uncapped entitlement, it's just a key source of revenue for health and behavioral health services. But Medicaid agencies are under a lot of pressure and are concerned about increasing costs and identifying financial actions because, as you know, Medicaid is a state and federal run program. So the feds are picking up at least 50%, some cases higher for poor states, 70%. But still, the state has to come up with the match to complete the 100%. And so we'll look at some of those opportunities for generating match as we move on here. So the next slide is about where to look for money and other support. And these other boxes around things like foundations and business, corporate giving, they're really important for flexible kinds of contributions. And I don't want to minimize them because they are very key for that in that respect. And third-party reimbursements from commercial insurance are also critical, if for no other reason than I don't think we should be letting commercial insurers off the hook. Historically they have relied on the public sector to provide community-based care, more of what we think of as long-term care services, and we need to really be doing more with the commercial sector about funding community-based services. And they're under increasing pressures to fund longer-term residential stays, like inpatient stays. They should be looking for more cost-effective home community-based alternatives. Well, the point I want to make also about this slide is that none of these other boxes begin to compare with the size of the dollars in the government box. And so you really have to look at how any of the agencies that are spending dollars on your population's focus, how are they spending the dollars? Are you getting the best value for them? Are they being spent in ways that still achieve your outcomes? Because even if they weren't a large source of funding, you don't want them going off in one direction that's not productive, given where your cross-stakeholder group is saying that doesn't make sense. Okay, the next box has to do with financing strategy. So there are really only three ways of financing a system, to simplify this. This is the point that Mark Friedman made some years ago. Mark used to work at the Maryland years ago, continues to do work around results-based accountability and such, but you can redirect dollars or redeploy from places where you're spending what I call high-cost, low-outcome services or high-cost, poor-outcome services. That's one major strategy, because there often are not new dollars in children's services. So you've got to look at opportunities to redirect. Refinancing, which is maximizing entitlement spend, in particularly Medicaid, which you can do in any number of ways. You can expand the types of services that Medicaid will cover, particularly home and community-based alternatives. And that May 7th, 2013 bulletin that the Centers for Medicare and Medicaid Services came out with provided guidance to state Medicaid directors on what a good behavioral health benefit for children should look like. There was another in January of 2015 that looked at a good youth substance use benefit. I think we have links to both of them at the end of this. But refinancing is another major strategy. And the third is raising new revenue, which is a longer-term strategy, but not unheard of. So, for example, special taxes, like, Proposition 63 in California that levied an additional tax on the income of millionaires, all of which goes towards mental health services. This is probably one of the better known. And then there are financing structures that support your goals. And if you go to the next slide, by those structures, there are things like blending and pooling funds, rating funds where you're kind of virtually combining them, or you're just intentionally coordinating dollars. There are also structures like single-payer systems, like New Jersey has set up, which I'll talk about in a second. And so there are these three strategies, and then there are structures. So let's talk about the three strategies. Redirection, which is the next slide, that is, to really do that stand, and the typical places one looks are residential and group care, detention, hospital admissions or readmissions, emergency room use, even too long stays in therapeutic foster care. Therapeutic foster care can be an effective practice, and depending upon the model, can be an evidence-based practice. But children can get stuck in therapeutic foster care, so that's another thing to look at. Inappropriate psychotropic med use if children are on multiple antipsychotics. For example, antipsychotics are not only off-label use for children, but they are very expensive. And even things like cookie-cutter psychiatric and psychological evaluations, which often are court-ordered. And children have, massive files with evaluations, but not necessarily leading to appropriate services. That may be an opportunity for introducing standardized screening and assessment, for example, across districts for your population. Okay, so let's talk about some examples. The next slide, which is a picture of Wraparound Milwaukee, is an example of both pooled funding and redirection. I'm assuming most of you are familiar with Wraparound Milwaukee at this point. But they truly have pooled money. I mean, they started out years ago with the mental health system controlling maybe about $4 million, most of which was tied up in their adolescent psychiatric beds, which they long ago closed. And child welfare was the major financer of residential treatment. And that's where they began, with children who were in or on their way to residential treatment. And they redirected the dollars to the Children's Mental Health Agency, which set itself up as really a managed care organization, or care management organization, and contracted out with 8 care coordination entities, and built a provider network of over 200 providers, about 70 of which are culturally, linguistically diverse providers. So they really have, they've gone from this very bed-based kind of not very well-funded system, well, not really a system, to a system of care that serves maybe about 1,200 youth a year that gives them enormous flexibility. They also focused on a group of youth that were going to the state training school, adjudicated youth, where the judge stays the order and instead diverts them to wrap around Milwaukee. And because so many, and the county actually had an incentive for that, because in Wisconsin counties pay for stays in the state training school corrections facility. And so the state has been able to close beds because so many of the youth historically have come from Milwaukee County, and now they're being converted. So that's an example of pooled funding and redirection. And they drastically reduced their length of stay and number of beds in residential treatment. As I noted, they closed their public adolescent psych facility. An example in the next slide of graded funding and redirection is Cuyahoga County, which is Cleveland, which is focusing on kind of a little bit of a broader spectrum of children. So children at risk for child welfare involvement. Cleveland was one of the first Casey Foundation neighborhood collaboratives where very indigenous neighborhood organizations are set up in order to wrap supports around families that are at risk for child welfare involvement. And so they built on those and their formal providers, child welfare providers who are also Medicaid providers, in what they call care coordination partnerships at neighborhood levels. And so they focus on children at risk from child welfare, youth that are in or on their way to either residential or detention who could be converted, youth with status offenses who historically had received short-term shelter bed stays without much service or support and ended up rebounding back into juvenile justice involvement. And then there was a subset of the early childhood population where they felt they were not, they have a very good early childhood care, but there was a group of families they felt they weren't able to reach or engage, and if they could include those children in these care coordination partnerships, then they could bring the resources to bear of the early childhood system. And so they identified in the box here all of these different financing streams that support these various populations. And the Deputy Administrator for Human Services set up, in effect, an administrative service organization that they call the System of Care Office. And these dollars didn't leave their home agencies, but a memorandum of agreement was developed across them that stipulates that the plans of care developed at the neighborhood level, that these dollars will be capped to support those plans of care. And that's approved at the System of Care Office level, and the dollars, capped that way. So that's kind of more graded funding and redirection. The next one is an example of refinancing, again using Milwaukee, where they have a very good mobile responsive stabilization service, kind of a newer generation. And some of you I know have been to the TA Network's mobile responsive stabilization meeting in New Jersey. Milwaukee is also part of that meeting. And the New Jersey mobile response is actually built, it was, adapted from the Milwaukee model. Anyhow, the schools and child welfare wanted dedicated teams. And so they contributed $450,000 each to expand mobile response stabilization in order to prevent placement disruptions in child welfare and to prevent school expulsion. And because mobile response is a Medicaid billable service in Wisconsin, and they have a really nice benefit, that's what it's described, the contributions from the schools and child welfare actually generate additional match. So the the child welfare generates an additional $200,000 match. So the $450,000 becomes a $650,000 program expansion. And they've been tracking placement disruption rates, and they've brought that down and credit that to a great extent to mobile response. And that's also an example of how Medicaid is. You can help to address that issue of where's the match coming from. If it's a key service for a constituency like child welfare, it can make a difference in outcomes they're trying to achieve, like placement disruption. And virtually all of their children are child welfare. It's kind of a no-brainer, not, it would be sort of crazy not to do it. New Jersey also reallocated child welfare and mental health general revenue in order to enhance match for their Medicaid system of care innovations. If you go to the next slide, in the early days when New Jersey was kind of just building its system of care, they significantly expanded their Medicaid rehabilitation services option to cover in-home services, certain evidence-based practices, mobile responsive stabilization and therapeutic foster care. And then they also revamped targeted case management to support an intensive care coordination, fidelity wraparound approach using locally based care management entities. And then they use dedicated administrative dollars to support their family-run organizations, which are also locally based, and to support a statewide system administrator, which is a managed care company, which functions as a non-risk-based administrative service organization. More recently, they are now using an 1115 Medicaid research and demonstration waiver in order to expand their substance use treatment services. If you go to the next slide, it's a picture of the New Jersey system. And when they first started out, they were focusing on children with serious mental health challenges, including those with co-occurring substance and intellectual and developmental disabilities, but primarily children with mental health challenges. And in the last couple, not even 2 years, a year and a half, they have expanded their populations to include all youth with substance use challenges, not just co-occurring, and all children with intellectual developmental symptoms, not just co-occurring. And so that has implications for the types of services, for the kind of financing, and so again, as you're adapting your population to focus, you have to go back to your financing, your strategic financing plan, and say, okay, now where are we looking, and who spends dollars, and how can we redirect or refinance? The next slide, which is raising new revenue, is just a couple of examples, starting with the one in Prop 63 in California, which went the income tax route. Spokane, Washington went a sales tax route. Jackson County, Kansas went a property tax route. There are several Florida counties that have children's trust funds. And there are social impact bonds, which sort of a newer way of thinking about financing, where a group of independent investors, in effect, is saying, okay, we'll upfront the money for this systems change and expect a return on investment of our dollars because you're focusing on something of which you could produce a return on investment, for example, reductions in residential treatment or detention use. All of those, in terms of new revenue, it takes political will, it takes public will, it may take longer, so it's maybe a longer-term financing strategy, but certainly, worth paying attention to. And if we go to the next slide, so you've figured out kind of how you're going to finance things, what dollars you're going to use, and if you're redirecting and you're refinancing and what those strategies look like. In most systems, you're contracting for services support and often care coordination as well, and for things like family and youth-run capacity building, training. And so another thing to look at is what are the purchasing strategies that we're going to be using? So how do you use your dollars to buy value and not just fund a program the way we kind of historically have funded things? And so examples of value-based purchasing where providers may be rewarded with bonuses or share in savings or penalized, reductions in payments, for example, based on meeting pre-established targets or benchmarks. One might use population-based case rates, and Milwaukee uses those. So child welfare pays the Children's Mental Health Agency a case rate in order to manage and provide care for children that they're diverting from residential treatment. Various managed care organization structures are ways that you can build in contractual specifications that have performance-based indicators attached to them. Care management entities like in Georgia or Jersey, where you're setting up organizations to do intensive care coordination around a subset of children, usually using fidelity wraparound. And so there are various approaches to purchasing as well that need to be looked at as kind of hand in glove with financing. Okay, the next slide, which has to do with sort of just summarizing, doing a cross-agency analysis of expenditures utilization. And we did a brief on this that I think also there's a link to with this webinar. But you're basically saying, okay, which state and/or county agencies spend dollars on our populations of focus? How much do they spend in total and by service type? What are they buying in effect or spending? How many children use services? How much do they use? And what are the characteristics of these children? You want to kind of engage in that analysis to get a good picture of what's going on. What are your dollars buying? Because there are often a lot of urban legends or rural legends about what's going on in the system. And the thing is, when you look at expenditure data, utilization expenditure data, it tells you what's going on. It doesn't necessarily tell you why, but it tells you what you're doing. So and Medicaid is a big place to be able to look at expenditure and utilization data because they have the data. They have to report these data to the feds. There is a lag time, so you may not get current or last fiscal year, but the year before certainly. Medicaid may not have the time because they're overburdened to do this analysis for you, but you could use some of your system of care dollars, grant dollars, to buy some staff capacity in order to help do this kind of analysis. Okay, so then the next slide, Beth, where you're trying to answer the question again about what the opportunities are. By doing that analysis, it will tell you what the opportunities are for redirection or maximizing revenue, and where you might show a return on investment. Okay. I want to give you an example also of how you can use financial analysis data in the next slide, because often you have to, these data not only tell you all, and by you I mean whoever your cross-system stakeholder group is, what's going on and what the kind of opportunities are, but you may need to use your data to make a point with others, like legislators or Medicaid staff or governor's office staff. So we've been doing this analysis of the Medicaid max data, which are all of the data on all children in Medicaid, so 30 million children in Medicaid, looking at the mental health and substance use treatment services that children are using and what the expenses associated with that use. We're also looking at psychotropic medication use. And so one of the things that we've been looking at the max data, there's a lag time in the max data, but we started with the 2005 data. We looked at 2008. We're now looking at 2011, which is the most recent data available. And one of the things that's absolutely clear is that the subset of children in Medicaid who use behavioral health care, they have mean Medicaid expenditures that are over 4 times higher than Medicaid children who do not use behavioral health care. So they're an expensive population. And if you stratify them by age category and look at the foster care population and children on SSI, they're even more expensive. Foster care is 5.5 times higher. Children on SSI, 8 times higher. And we also looked at the expenditures for the top 10% most expensive children. And what's interesting is that their expense is driven much more by behavioral health service use than by physical health service use, which is the opposite from adults with serious mental illness. and where their costs are driven by physical health care use because they have so many comorbid physical health conditions like heart disease, chronic obstructive pulmonary disease, diabetes. You don't see that with children in Medicaid who use behavioral health care. These children, yes, they're not as healthy as children in Medicaid who don't use behavioral health care, and children in Medicaid are not as healthy as children in general. But you don't see the really high rates of comorbidity in children that you see in adults. And when you do, it tends to be where there are comorbid physical health conditions. It tends to be things like asthma, which are relatively low cost in comparison to the adult to manage, in comparison to the adult conditions. That has implications for how you organize services in children's, systems. So care coordination. If the major driver is physical health care, then it probably makes sense to have physical health organizations be managing care with connection to behavioral health. But if the major driver is behavioral health care, does that make sense for children with significant behavioral health conditions? So it's at least worth having the conversation, as important as it is to make sure there's coordination between primary care and behavioral health care. You also have to think through, what are the major drivers and what's the major set of conditions that the family's having to deal with, and where does it make the most sense to establish care coordination. So these financial data can also help lead you in a direction toward how you want to organize your service delivery system as well. If you go to the next slide, in terms of what drives costs, we mentioned a number of them earlier, but if looking at our Medicaid MAX data, residential treatment and group care remains the #1 cost driver. And it has since the 2005, it was true in 2008, it's true in 2011. And use of psychotropic medication is also a big cost driver. Use of traditional outpatient therapy, which, there's really a lack of evidence, particularly for populations like children and child welfare, that traditional sort of inside-based 50-minute hours are that useful as compared to more evidence-based practices like trauma-focused cognitive behavioral therapy, for example, or functional family therapy. So if you continue to do what doesn't work, that's like throwing, good money after bad. All right, the next one is your financial data can also point you in the direction of where you have racial disparity and disproportionality. So this is a picture of Medicaid enrollment and behavioral health service use by race and ethnicity. It has historically been true, and it continues to be true, that white children are overrepresented in the population of children who use behavioral health services. So we could reframe that as saying they seem to have better access to behavioral health care. They represent 37% of Medicaid enrollment in 2011, but 47% of the population of children using behavioral health services. There are other populations like Hispanic Latino children, for example, represent 28% of the Medicaid population, but only 17% of those using services. So that is the disparity in access. And if you stratify some of your service use data like residential treatment or psychotropic med use, you'll begin to identify either disparities or disproportionality. So the next slide, you're trying at the end of the day to identify win-win scenarios across your major system purchasers or funders. And in order to identify those win-win scenarios, you have to know what it is that these systems are spending money on to begin with, and what it is they're trying to achieve within their mandates and their populations of focus. There are any number of states with child welfare lawsuits, for example, that have well-being indicators in their consent decrees, and well-being is well-being is a major focus of child welfare systems, and of child welfare nationally as well. And if you look at the well-being issues, so many of them have to do with access to appropriate behavioral health care. So that has implications for, what might the child welfare system be interested in? And, Medicaid, the same thing, increasing number of states. Medicaid is paying for psych residential treatment facilities, which are very expensive. They're seeing, and we saw this in the 2011 Medicaid data, we saw an uptick in the use of psychiatric uptick in the use of psychiatric hospitalizations for children. After seeing that go down, of course, when it went down, residential went up. Now they're both going up a little bit, and so Medicaid's concerned about that. If there are more effective alternatives, and we know that there are, and that's what you're trying to build. So the next slide, summarizing financing strategies. You have to maximize Medicaid. You have to look at least intentionally coordinating your funds across systems for the same population of children.
Sheila, we can't hear you. Okay, we seem to have lost Sheila for a moment. Hopefully she'll dial back in. But to summarize the financing strategies that she's gone over is maximizing Medicaid first of all. And we know, and as she emphasized, Medicaid is a primary financing source for many of the home and community-based services that are provided through systems of care. We do know that the future of Medicaid is in question. There have been a lot of proposals for changes, but it remains the strongest funding opportunity now, and maximizing that is important for maintaining our systems of care. Braiding, blending, coordinating funding streams across systems is also one of the strategies that you should be looking at. As you know, we share the same populations, and in general, there are more mental health, behavioral health funds in our partner-serving systems than there are in behavioral health systems. So redirecting not only behavioral health funds, but also funds from our partner-serving systems from the high-cost services like residential inpatient to effective home and community-based practices is another important strategy. Managing dollars through managed care arrangements or care management organizations that are based on the system of care approach using home and community-based services is another important strategy for you to look at. Using those kinds of structures to manage care and costs for the highest need populations have been found pretty effective in controlling costs and doing that redirection from the juvenile justice facilities, from out-of-home placements in child welfare, from psych hospitals, from PRTFs and such, and the return on investment dollars that the return on investment data shows that those structures have been effective in doing that. Risk adjustment for complex populations is an important strategy so that organizations that take on the risk of serving those high-need populations also have some assurance that they have higher rates to serve the most high-need, complex need populations, and using case rates and structures like that, capitation case rates, to provide us, particularly case rates for the highest need children, have provided a way to increase flexibility as well. And in summary, also financing.
Hello?
You back?
Yeah, but what happened?
You dropped off for a moment, and I was doing your summary slide. I'm up to the last bullet, finance, so if you could pick it up from there on the summary slide, that'd be great.
Did everybody hear me through creating win-win scenarios?
Yes, yes, it just dropped off on the summary slide, and I went through the beginning, so pick up under finance, Sheila, the last major bullet.
Okay, well, it really was just sort of summarizing what I'd already said,
right,
in terms of maximizing Medicaid, but right. And that most, child behavioral health care services today are in managed care arrangements. So managed care organizations and Medicaid purchasers are really key partners in influencing Medicaid contracts and what and the understanding of managed care organizations about your populations of focus are really critical. And then risk adjusting payment for complex populations of children, so children in child welfare or children with significant behavioral health challenges, is also really key. Sometimes people get very upset with managed care organizations because they don't feel like they're providing sufficient level of service or access to tiny populations. But when you look at what their contractual obligations are, and more importantly, what their taxation rate is, what they've been paid to do what they're supposed to be doing, there's no way they can provide the range of services that for access that one would like to see. So, all of these things are important to pay attention to. And I think that was, and then also I was going to end by saying, don't forget that system capacity, like training, like the family youth front, organizational capacity, which are really critical to finance. And now I think I'm done. Am I still being heard?
You are, and Denise, I think you've been keeping track of some questions. So if you could go over that now, that would be great.
I can. Our first question, Sheila, is from Bonnie in Indiana.
Hi.
And I'm so sorry because I can't. So here she is. She would like you to provide some insight on how approaches to financing, development, and change might be different in system of care at the local level as opposed to those at the state and tribal levels.
I think, first of all, it depends upon how your state is structured. In Indiana, you're a county-structured state, right? So your county has a fair amount of control over its dollars. And that, I don't think the approach is really much different. It's just that there are certain, you still need to involve the state agencies as partners, and Medicaid in particular is probably still controlled at the state level. So it kind of depends. And then if you're in a state-run system, like in New Jersey, you really, where the counties don't have their own taxing authority, or they don't contribute dollars to children's behavioral health care, or generate Medicaid match, or generate child welfare match, or then you really do have to work close to the state on the finance system. You're not controlling very much.
Sheila, your voice is trailing a little bit more from the phone now.
Okay, I'll put it closer to me. Okay. All right?
That's better. Thank you. And so, Bonnie, if that we could provide some individualized technical assistance with the specifics for your county, Elkhart, if that would be helpful. And Bonnie,
a lot of it really, I think a lot of it has to do too with just sort of, sitting down thinking about, okay, how is our financing structured in our state? Does the state really retain control over most things, and for everything, or do we have a fair amount of autonomy at a county level? And begin with that analysis, and then you can kind of look at who needs to be involved and for what purpose.
Thanks, Sheila. There's another question from Delphi Roach. She had to get off the webinar for an appointment, but we said we would follow up with her. But she was asking about more information about Medicaid administrative billing for family support organizations.
Well, I think it would be best if Delphi had a conversation with New Jersey about that, because they've been doing that for so many years, and because they're family-run organizations, do things like outreach and engagement to Medicaid-eligible families. They help families get enrolled in Medicaid. They help families with system navigation. All of those are Medicaid billable administrative activities. So, New Jersey does a cost allocation plan to determine, what the level of effort is, in effect, with its family-run organizations around what can be Medicaid billable admin activities, and uses those dollars to fund them.
Great. We'll most certainly connect her with New Jersey. after this webinar. And then for those of you that are interested in other resources as far as Medicaid billing for peer support, we do have a lot of those resources available for you if you're interested.
If you have other questions, feel free to put them in the chat box now. Okay. Maybe one more.
I want to thank Sheila and Beth. I've never done a webinar with a presenter in a vehicle.
I am so sorry.
Thank you.
I'm so sorry to do it.
You did a fabulous job. There were a couple little times that you faded in and out, and then Beth picked up seamlessly when you dropped off somewhere on 95 there, and I think I know exactly where that gap is.
Yeah.
I have a couple more things I want to mention before we close. One is that there are documents that are available to download on the bottom right-hand of your screen under the chat box. And we will be adding a couple of more documents that we didn't put in there originally, but that may be helpful to you. There is a brief document that gives some guidance in developing a financing plan, and apologize for neglecting to put that up. It's also part of the toolkit on system of care expansion that many of you already have, and we will also make that available to you. I wanted to mention also that there is a webinar tomorrow on return on investment in systems of care. The link to register for that has been in the TA Telegram, and we can resend that to you also. But since return on investment ROI was mentioned a couple of times during this webinar and how you demonstrate cost savings when shifting your dollars from high cost, as Sheila said, high cost, low outcome services to home and community-based service approaches that do have a good and emerging evidence base behind them, that methods and guidance to develop ways of measuring ROI may be helpful to you. One of our guides that's available for download is on how to measure ROI, but there's a webinar that will provide some of that guidance and data tomorrow if you're interested in that. And I also wanted to mention the grantee meeting. For those of you that are System of Care Expansion grantees, and some of you may not be grantees, there is a meeting at the end of May in the Washington, D.C. area. I'm assuming most of you know about that. It's an opportunity to send people who are key partners or a team for team building, as well as an experience to become more knowledgeable about the system of care approach, the basics, and about system of care expansion approaches and how that works, and to bring some key partners who may not have a strong grounding already in the approach and in system of care expansion strategies. So Denise, Sheila, in case you have anything else to add, this would be the time to do it.
No, I don't think so. For anybody that applied, I guess I will add something. Anybody that has applied to the Medicaid Managed Care Academy in July, we should be getting notifications out within the next, I would say, week and a half.
Great. Perfect. And for the grantee meeting, there was a deadline, but I believe that's extended, correct, Denise?
The deadline is currently at the end of this week, but if you're interested, the meeting is on May 22nd and May 23rd in Rockville, Maryland. It's very close to SAMHSA's office, so there will be an opportunity to meet with GPOs as well. So shoot us an email if you don't know about the event and would like to participate.
Okay. If any of you have questions following